Okay, good morning. Welcome to Valley View University. Thank you everyone for joining today. I'm going to start by introducing myself. My name is Dr. Haley Hoffman. I am a family practice physician here at Roaring Fork Family Practice. We have offices both here in Willits and in Carbondale, and I work primarily in our Willits location. I grew up locally in the Valley, and it's been amazing to be back here providing care for all of you. So, a few housekeeping items before we get started. You can submit questions through the Q&A chat on the bottom of your screen. Your question could be answered live at the end of the presentation. We will try our best to answer your questions, and it's important to remember we're unable to answer questions regarding personal health information. So that being said, we'll go ahead and get started. Okay, so this presentation is going to be about navigating the change between perimenopause and menopause. So what every woman should know about this time period in transition. Okay, so we're going to start by going over some learning objectives, what I hope you guys gain out of this presentation. We're going to define perimenopause and menopause. We're going to review the common symptoms that you might experience. We will go over diagnostic testing, and we are going to talk about treatment options today. So how do we define this time? We define menopause when someone has not had a period for 12 consecutive months. So this is a diagnosis we make after the fact. So we don't know someone is postmenopausal until those periods have stopped for 1 year. Perimenopause is this transition into menopause, or the time leading up to menopause. You can see in this chart, perimenopause on average, and these are big averages, lasts 3 to 7 years. A lot of women will start to experience these changes in their late 40s, early 50s, but a lot of times even earlier than that. The average age of menopause in the US is 51 years old. We consider postmenopause the phase after menopause. So you haven't had a period for 12 months, and postmenopause lasts till the end of your lifespan. So this is a review of the menstrual cycle. We're not going to spend a lot of time on this, but it's really important to remember that there are several different hormones involved in the menstrual cycle that are going to be affected as you move into perimenopause and menopause. So one of the hormones that we're going to talk about later is FSH. This hormone's made in your brain, and it tells your ovaries to grow follicles. This is when you're still having regular menstrual cycles. Estrogen is one of the most important hormones we're going to talk about. This is made by your ovaries, and as the follicles grow, the estrogen levels are going to increase. This sends a signal to your brain to release more of the LH hormone, which is going to trigger ovulation. And then we see progesterone, which is made also in your ovaries, and it prepares the uterine lining for implantation. So these are going to be our key players in this process. Why? So why do we go through perimenopause in the first place? So women are actually born with all the eggs they will ever have. Every month you lose eggs. So starting before you're even born, you have lost some of the eggs that you had when you were still in utero. If we look at this chart, sometime around the age of 38, we see a more significant decline. It starts to accelerate. Once the egg counts drop to a critical level, the body can't maintain those regular periods anymore, and that's when we start to see no periods at all. So what happens to your hormones during this time? So as our egg supply dwindles, the normal feedback between our ovaries and our estrogen levels and the FSH in the brain, that becomes disrupted, and essentially the system goes haywire. So this is really important to understand that premenopausally, this graph we're looking at, we're showing our estradiol levels, our estrogen levels. During premenopause, they go up and down throughout our cycle, but it's a pretty smooth transition and it's consistent. Perimenopause, it's up, down, up, down, up, down. It's all over the place. So this is when our periods become irregular, we start developing symptoms. In menopause, there's no more functional eggs left. We stop making these estrogen and progesterone hormones, and we get a smoother, more leveled out hormone level. So some of the symptoms that we see, and we're going to not go through all of these, but a lot of them. It's important to remember that this process is part of normal aging. So as we age, our ovaries age, and this is a normal process. That doesn't mean, though, that it's not full of symptoms and uncomfortable. So hot flash is probably the most recognized symptom. And the reason this happens is we are getting these estrogen fluctuations. It's changing the amount of FSH in our brain. Our brain is trying to push out more FSH and tell our ovaries we need more estrogen, pump out more estrogen. This is also happening in the thermoregulation center in your brain. And so we think that's why the temperature control goes out of whack as our hormones go out of whack. We also know a lot of women experience fatigue, physical exhaustion, mental exhaustion, irritability. So, as you just saw, those hormones going all over the place, those erratic fluctuations are going to affect your mood. We see a significant amount of depression and anxiety, and it's important to know that even in women who have never experienced depression or anxiety in their lifetime, they're 2 to 3 times more likely to experience these symptoms during this menopausal time. We see sleep problems, insomnia, digestion problems, and then another big one is vaginal changes. The vaginal tissue in our entire genitourinary system is really sensitive to estrogen. So as those levels drop, the lining in the vagina becomes thinner, blood flow decreases, lubrication decreases, the pH actually changes, and we see women become more susceptible to infections. So how do we diagnose menopause and perimenopause? For the majority of women, in their 40s and 50s, we actually don't need to do hormone testing. It's not necessary to make a diagnosis. Remember, our hormones are going up, down, up, down. So at any given time, you come to an appointment with your provider and you want your hormones checked, they might be normal, they might be really high that day, they might be really low that day. There's no single reliable test that can tell us when you're in perimenopause. This is really frustrating, but it's helpful because we're going to treat you based on symptoms. And we will talk about that next. So it's important to have your general health labs checked because that can influence how we treat your symptoms. There's conditions that mimic perimenopause. So a lot of times we will check other labs, maybe your thyroid. And there are a lot of tests out there that are marketed directly to consumers. These are things like maybe urine hormone testing or salivary hormone testing. These are not FDA approved tests. They are not very accurate, and we don't recommend that you spend your time or money doing them because it's not going to tell you much, and we're going to treat regardless of what we learn there. All right, so when do we treat and what are the next steps? The most important is, are you having symptoms? So when you come to your provider and you start to notice these symptoms, that's going to be the marker of maybe it's time to treat. We like to start at low appropriate doses and adjust based on your symptoms. So we don't actually have to check your levels. It's important to know it's not the actual absolute value of hormones that's dictating your symptoms. It's going to be how your brain responds to these fluctuations. So for every woman, that's going to be different, and we are going to use your symptoms to guide us in your treatment. There are certain situations where we do check certain levels, and we will talk more about that as we go. What are the benefits of treatment? So why do we care about treating perimenopause and menopause? The most important is we want you to feel your best self. So managing your symptoms. These are things that we can treat, and we have a lot of great medication options. We can protect your bones. So if we start using hormone replacement earlier on, before you ever develop osteoporosis, we see a benefit in protecting your bones. The second we stop the hormones, we don't have that benefit anymore. As far as cardiovascular health, we know that when we use hormones at an appropriate dose and an appropriate time, that there actually is a reduced risk of type 2 diabetes and coronary heart disease. we see a reduction in colorectal cancer, which is a great benefit. And dementia risk, the evidence here is neutral, meaning maybe it does nothing, maybe it helps prevent dementia. The most important part of this, though, is the window in which we're treating. So the risks and benefits are going to vary substantially by age. In women between 50 and 59 who we begin treatment within 10 years of that menopause transition, we have a more favorable risk-benefit profile. So we're going to see more benefits than we do risks. As we age, that's going to change. And as we have more and more evidence, we're going to have new studies that tell us maybe we can treat for longer than we used to or start later than we used to. What are the risks? So nothing is without risk, and these are really important to remember. Breast cancer is probably the most talked about or the biggest concern from a patient perspective. We know though, from the studies we have, in women who don't have a uterus, we've had a hysterectomy, when we use estrogen alone, the risk is neutral or even favorable. But we do know that in past studies, there has been some increased risk in combined therapy, so estrogen and progesterone. One way to think about it is if you have a breast cancer that is estrogen receptor positive and we give you estrogen, we are going to feed that cancer. This is why it's really important before you start HRT that if you are of the age you need to be screened, that you see your provider and you get your annual mammograms, make sure you're up to date on all of these things. Another risk is blood clots. So venous thromboembolism, we see an increased risk of clotting with hormone therapy. And we're going to talk about the details of that in a minute. And then cardiovascular health, just the flip side of the benefits is if you already have cardiovascular disease, we start you on HRT, we can sometimes see an acceleration or an increased risk of things like stroke. And this risk goes up substantially if you are 70 or older at the time that we're starting hormones. What's interesting here is that the type of progesterone matters. So we're going to talk about the different types of progesterone, and we now prefer to use an FDA-approved product that has much lower risk of these things than some of the other treatments we used to use. Okay, so let's talk about some generalizations when we treat. Like I said, there's several different FDA-approved products. If you have a uterus and we treat you with estrogen, in general, we need to use progesterone to protect that lining in your uterus. Estrogen tells the lining of the uterus to grow and become thicker. Progesterone then kind of seals that lining. If we're not using it, we can let that growth get out of control and it's dangerous. We worry about things like cancer down the line. So this is an important thing to remember. Another important thing to remember when we're using hormones during perimenopause, if you are still having regular periods and you could still become pregnant, these lower doses of HRT is not enough to prevent pregnancy. So that is something that's going to come into play as we decide how to treat. So let's talk about what bioidentical means and what bioidentical hormones are. So bioidentical hormones are hormones that are chemically and structurally identical to the hormones that your body is already making. There are FDA-approved bioidentical hormones, so we can prescribe hormones that are identical to the ones your body's making. And then there's compounded bioidentical hormones. So the compounded bioidenticals, those are going to be custom mixed preparations through a compounding pharmacy. These are not FDA approved, meaning they're not safety tested, they're not tested for efficacy, they're not tested for potency. And we see some inconsistencies in the amount of medication per bottle that you get. So maybe you're using a compounded cream where we can't say for sure you're going to get as much hormone in the top of that bottle as you are in the bottom of that bottle. And that's why we are going to lean towards those FDA-approved products. We do use compoundeds all the time, though, and there are some situations where maybe you have an allergy to the products that we prefer, and compounding might be a better option for you. So systemic estrogen. So this is the first hormone that we're going to talk about when it comes to treatment. So there's a couple different ways that we can deliver estrogen to the body. So estradiol, mimicking that same hormone that's made by your ovaries. If we use it as a transdermal formulation, we deliver it through the skin. So these are going to be things like an estrogen patch, an estrogen gel. There's actually an estrogen spray that you can use. These are FDA approved products, and we like them because we get to bypass the liver and we see a lower risk of these side effects that we worry about. So because you're not swallowing it, we're not seeing it get passed through the liver, and we don't see an increase in the clotting factors or the elevated inflammatory markers or even the elevated cholesterol that we see with, say, the oral product. So I would say, as a broad statement, most providers are going to prefer one of these transdermal formulations because they are one of the safer options. There's also a vaginal ring. You can see it here that goes in the vagina, and it is high enough, the doses in this ring are high enough to create systemic estrogen effects. This is another great option. And then there's oral pills. So those are pills that you take every day. Because you swallow it, it passes through your GI tract, it gets metabolized in your liver, and then it goes into the bloodstream. And we do worry about a higher risk of blood clots, higher cholesterol with these products. That doesn't mean we don't use them. They're convenient, they're affordable, and everyone is different. When it comes to the patch, we also know that it actually has the best evidence for sexual health. So in women who are experiencing decreased libido or sexual health symptoms, we see the best results when we use the patch. All right, we're not going to go over this in detail. This is just to show you all that there are a lot of approved products that we can send to your pharmacy at a ton of different doses. So this is a large menu. We have a lot of options, and that's great because we can find something that works for everyone. The next hormone we're going to talk about is progesterone. So remember, if you have a uterus and we give you estrogen, we also want to use progesterone. Progesterone comes in a couple different forms. So micronized progesterone, that is the oral pill that you swallow. It's bioidentical to the hormone produced in your body. You can either take it every night at bedtime or 12 days of the month. We call this cyclic dosing. We typically recommend every single night at bedtime because it has a calming effect. It helps with insomnia. And so we like to use it every single night. The sources of micronized progesterone are plant sources, and there's two different doses, either 100 or 200. These are generalizations. But the benefit of this form of progesterone is we do see the lower risks of breast cancer compared to these synthetic progestins that you see below, and we'll talk about those in a second. It's important to know that the brand name Prometrium of micronized progesterone has peanut oil in it. So if you are allergic to peanuts, this is not for you. Just remember that. Make sure you tell your provider. Sometimes we'll use this form of progesterone vaginally. This is off-label, but we have some options. And the next group of progesterone-like hormones we're going to talk about are progestins. So these are synthetic. They're made in the lab, and they are hormones that have progesterone-like effects, but they are not chemically identical to progesterone. One of these is medroxyprogesterone. This is the hormone that was used in the WHI study, which maybe some of you know about. It was a large study many years ago that created a lot of fear about HRT. And so in that study, we did see higher rates of cardiovascular disease and of breast cancer when we used this form. So we don't often use this as part of HRT. We use it all the time for other things, but not traditionally part of our HRT. Another form is going to be called norethindrone. So you probably recognize this from birth control pills. This is the form of progesterone that's in a lot of birth control pills. And it's also in some combination pills. So there are some HRT for menopause combination progesterone estrogen pills that have this form in it. And then there's the form of progestin that's in IUD devices. So these are going to be things like Mirena or Kyleena. And we like this form because it also controls bleeding. So if you're someone who during perimenopause and that menopausal transition, you're having a ton of abnormal bleeding, this is a really helpful way to stabilize that bleeding. Sometimes we'll use it along with the oral form to get those calming effects. We also like this because it prevents pregnancy. So if you can still become pregnant, it's a great option in addition to the other medications. All right, the next hormone we're going to talk about is testosterone. So women's bodies make testosterone. It's not just a male sex hormone. It's made in our ovaries and our adrenal glands, and it's involved in sexual desire, so your libido, sexual arousal and response, energy levels, healthy muscle, and an overall sense of well-being. What's interesting is testosterone starts to decline, not like this, like we saw with estrogen, progesterone, but it's kind of a slow, steady decline. And sometimes it'll start dropping before perimenopause. So it's not necessarily related to that perimenopausal time period. It's an age-based drop. So it starts dropping and then it's a slow decline. So there's no FDA approved product for women right now. That's going to change. HRT is a hot topic right now. I'm sure hopefully soon we will see something that's FDA approved for women. But we also, the only indication that a lot of insurance companies will approve this for is something called hypoactive sexual desire disorder, which is a fancy way of saying low libido. And that doesn't really matter because we are using these testosterone products regardless of that diagnosis or not. When we use testosterone, we are using it typically as a gel or a cream. So there is an FDA approved product for men, of course, but we can use a fractioned tiny dose of the male product for women. And so this is a gel. You can get it at the pharmacy. You use a half a milliliter, which is a really small amount. And sometimes we'll just say put a pea-sized amount on your fingertip or a dollop. And you use it every single day. This is often where we're going to use these compounded pharmacies to help us. Because we can decide exactly how much we want. And sometimes it might be more affordable than paying for this testosterone gel at the pharmacy. Sometimes the potency is not as consistent. And so testosterone is one hormone where we might check your levels and then repeat your levels after you've been using the product for about 6 weeks, just to make sure that we're not over treating you or even under treating you. At too high of levels, we can see acne, increased facial body hair, male pattern baldness, and nobody wants these things. And so that's why we're really careful with our testosterone. We like to know where your levels are at. There are vaginal-based treatments as well. So vaginal estrogen, this is different than the ring, the ring that can create systemic estrogen. These are products we just put in the vagina and they only act locally. So as a broad generalization, everyone can have vaginal estrogen and probably maybe everyone should at some point. You apply these to the vagina and we use them to treat vaginal dryness, painful intercourse, urinary symptoms. So if women are having frequent UTIs, this can be really helpful. There's really minimal systemic absorption, so we aren't worried about those risks we talked about earlier. And it's really effective. It works really well for those genitourinary symptoms. It's not going to treat your hot flashes. It's not going to protect your bones, but that's okay. It has its own use. It comes in a pill form. The pill form has an applicator. If you've ever used something like Monistat over the counter, similar idea. It's a plastic tube that you put the pill in and you insert it into the vagina. There's a cream, same thing, has an applicator. And then there's a ring, and the ring you can put in, leave for 3 months, change it 3 months later. A lot of times, if you already have this significant dryness or discomfort, we recommend just putting it on your finger. Put it on your finger, insert it into the vagina. And that's another way to do it. So DHEA, you might have heard about this hormone. there are a lot of supplements, so over-the-counter supplements, that some maybe social media or other influencers are recommending. We don't have evidence that if you take oral DHEA that it's doing much for your hormones. This hormone naturally in the body, it's converted into testosterone and estrogen. So theoretically, it could raise these levels. But we know that when we use it vaginally, it's actually really helpful. So there is an FDA approved product that's vaginal DHEA, and it works really well, but it's really, really expensive. So sometimes we will go to this if that vaginal estrogen isn't helping or if it's something that we have access to. All right, so non-hormone based treatments, this is important because not everyone wants to take hormones and not everyone can take hormones. So there are some medications that are approved for hot flashes. One is Veoza. They have a great ad on TV. If you're watching the Olympics, you've probably seen it. It's very catchy. This medication is something called a neurokinin 3 receptor antagonist. It's working in the brain, in that thermoregulatory system, responds to estrogen deficiencies, and it works well for hot flashes at night. You take it at bedtime. We like to monitor your liver function tests if you take this medicine. Paroxetine, there's a form of paroxetine, which is an SSRI that is approved for hot flashes. And then all of the SSRIs or SNRIs, which are medications we primarily use to treat mood, those have off-label uses, meaning they can be helpful for hot flashes. Not all of them work in everyone, and sometimes we have to try a couple. But this is helpful because a lot of women have those mood symptoms, and we can address two things at once sometimes with these meds. Gabapentin is another medication that has an off-label use. We don't see significant improvement, but it is worth trying if nothing else is working. And then there's some non-pharmacologic treatments, which we use in addition to hormones all the time. So cognitive behavioral therapy for insomnia, CBTI, is a great intervention for insomnia. Different mind-body interventions, exercise, yoga, acupuncture, all of these things are going to help, and they're certainly not going to hurt you. And we use them all the time. So what about pellets? We're not going to spend long here. The point really is to just remind everyone that the American College of Gynecology and the American Academy of Family Practice both recommend against pellet therapy. And we were going to talk about why. So pellets are these small, solid form of hormones. You can see it in the palm of this hand that get implanted under your skin. And then they slowly dissolve over 3 to 6 months. So once they're in, we cannot take them out. So if we overshoot the levels we're going for, especially with testosterone, there's no way to undo that. And we don't like giving patients products that we can't get rid of if they have side effects. And the biggest thing with pellets is that we have a safety concern that we often see supraphysiological levels of hormones, meaning levels that far exceed the normal range and are well outside of the goal of treatment. And then they're stuck in there, and then we can't get them out. So we see a lot more side effects with pellets. And recently there was a study that showed that over 50% of women will experience postmenopausal bleeding with these. And we take that very seriously when you have bleeding after menopause because it can indicate something is wrong to us. And we don't want you to have to go through extra procedures because your pellet therapy was too high. There's also something called tachyphylaxis. This is a phenomenon where your body needs higher and higher doses of the medication to achieve that same symptom relief. And we see that with pellets. We don't see that with the other products. But this is just another reason that if you've been getting pellet therapy and you want to switch to one of the FDA approved products, we have a lot of options to have a smoother control and to be able to start and stop these meds a lot more easily and quickly. All right, so that was a big overview of all of the different treatment option symptoms. the most important thing is that you talk to your provider. So your provider can go through your symptoms, talk about these options again, and then look at your health history to see what products might be best for you, what products might not be good for you. A lot of patients that we see have other diagnoses and they work with specialists for their other medical problems. And we work side by side with those specialists to make sure that we're making safe decisions when we use hormones. Um, if you want to learn more about hormones, there are a ton of different resources out there. I'm including two here just because I think they are reputable sources and they have some good information. They both have websites, they're both practicing physicians. And it's really important to use reputable evidence-based sources, especially in the times of TikTok and social media, because your provider is really going to be the best place to go with your questions. All right, so that is going to wrap up our presentation. We're going to move on to the Q&A section. I've included my sources for all these different studies. If you guys are interested, you'll be able to have access to this once this is uploaded.
Thank you, Dr. Hoffman. So we have several questions that came in during your presentation. First, are there ways to identify if symptoms are actually perimenopause versus a diagnosed thyroid issue versus GLP symptoms? How do we know when to get help? How do we request testing?
Okay, great question. So when we talked about the hormone testing and lab testing, thyroid is a really common mimicker. And so we will check your thyroid over and over again in your lifetime as a woman because it can mimic a lot of things. But if you are on appropriate thyroid medication and your thyroid levels are within our goal range and you're having symptoms, we might think maybe this is related to perimenopause. And so this is one of those situations where sometimes checking levels can be helpful. As far as GLP-1 side effects, I think that would be something that seeing your provider and talking about the details of the symptoms you're having can be helpful in teasing that out a little bit more.
When do you recommend starting vaginal estrogen cream? In only the presence of genitourinary symptoms or before?
Great question. I don't have the evidence-based answer here, but usually when you start to experience symptoms, right now, at least in my practice, I'm not using it preventatively. Postmenopausally, maybe we do start using it preventatively for things like UTIs, but in that perimenopausal time, we're usually starting it with symptoms.
If you are on an estrogen patch, would there be a case to also take estrogen vaginally, or is it one or the other?
This is a great question. It's not one or the other. So we will use vaginal estrogen alongside the patches all the time. Because we don't get those systemic effects of the vaginal estrogen, we don't worry about overshooting your estrogen goals. And if the patch or your systemic therapy isn't enough to control those genitourinary symptoms, we will often use both of them.
How does HRT affect weight, insulin resistance, cholesterol? What suggestions do you have for the weight gain?
Yeah, this is the million-dollar question. So we know, we saw in those charts that our hormones are going haywire and we see weight gain. We like to think that this is evolution is at play here. As women go through perimenopause and menopause, their bones become weaker. It can be natural for the body to store more fat and try and protect bones. There's other reasons this happens as well, but this is something that is really challenging to experience and to treat. So unfortunately, the HRT is not the magic wand for weight loss. So we don't see women automatically losing weight just because we put them on HRT. we might see their mood improve, their energy improve. They have time, they have the energy and create the time to start exercising. But this is where sometimes we will lean towards other medications depending on the degree of weight loss that somebody has. But this is a really challenging part of perimenopause to treat.
How do you differentiate severe premenstrual symptoms versus perimenopause?
This is also a really good question. This is probably a good time to have a conversation with a provider. Um, if you remember, everyone is going to respond to hormone changes differently. So it's not a problem with your hormones. Your hormones are doing what they're supposed to be doing. It's how our brain experiences these ups and downs, whether that's you're still having a normal cycle and those ups and downs, those drops are creating those severe PMDD or PMS symptoms, or perimenopause where your hormones are all over the place and your brain is having the same response. I would say this probably would depend maybe on your age, on the symptoms that you're having. The the good thing is that we can treat them the same way. So birth control pills are higher doses of HRT, and sometimes we will use that for severe PMS symptoms because we're then giving the body an even level of hormones throughout the cycle. And this is where those SSRI medications can be helpful for mood because they are approved for treating severe PMDD. So whether it's PMDD or PMS or perimenopause, we're going to treat it pretty similarly. But this can be tricky to figure out sometimes.
Do you have any tips related to severe fatigue related to perimenopause?
Um, so I think the slide that we had on non-pharmacologic treatment um, was probably underemphasized, but this is where the lifestyle factors can be really beneficial. It can be really challenging to treat just with hormones alone. Sometimes it's not enough, but we know we have evidence that exercise, moving your body actually helps if we can break through that fatigue. These other non-pharmacologic treatments can be really helpful. Sometimes the hormones are significantly helpful, and so the fatigue is a reason to try them. And then there are some off-label medications that I will use for those kind of chronic fatigue symptoms, and so that's something where talking to your provider can be really helpful.
Do you have any supplement recommendations?
Um, Great question. So in general, I like women to take vitamin D3. It protects your bones. It is good for your mood. It's a great supplement for most women to take throughout their entire lifetime. Later in perimenopause, menopause, we do recommend some calcium to protect your bones. Other than that, there are a handful of supplements that can be helpful, but we don't really have good evidence to tell us that like every woman should have them or no one should have them. Um, the resources that I shared, Dr. Mary Claire Haver, she has a website, she has a book. She actually goes through some of those supplements that can be helpful to try. The most important thing is that you talk to your provider about them so that we know what's helping what or what to watch out for if you're taking supplements because we have to be careful when we use supplements as well.
Can you say a bit more about the dosage of testosterone from the male approved testosterone? I've been using compounded cream, but I'd like to know what other options there are.
Yeah, great question. So I'm going to try sharing my presentation again here, and we're going to go back to our testosterone slide. So testosterone, so the compounded testosterone creams, the way that most of the providers in our organization are prescribing them to the compounded pharmacies is going to be the same dose that you would get if we prescribe a testosterone gel to a local pharmacy. So the gel, it's a 1% gel. And when you use that dollop or 0.5 milliliters, that's about 5 milligrams per day of testosterone. And that's usually around what most of us are prescribing, somewhere between 2 and 5 milligrams a day to the compounded pharmacy as well. So if you've noticed that maybe when you have had your levels checked, they're all over the place, like sometimes your levels are high, sometimes they're low, you might be someone that you're getting inconsistent potency in the compounded cream, and we try the testosterone gel. I will say, just from personal experience, there are still pharmacies and pharmacists that are really uncomfortable dispensing this for our female patients. That does not mean it's not safe. It just means that it's a male product. And so sometimes we get some resistance there. And sometimes your insurance will not cover it. And it might be less expensive to pay for a compounded cream than to pay out of pocket for the testosterone gel. When you get it at the pharmacy, it comes usually in these little packets. Our male patients would use an entire packet. You're going to use a really small amount. It's going to last you several days. But sometimes the math works out that it's more expensive to do it that way.
Any thoughts on diet and food choices in perimenopause and menopause? I know Mary Claire is a big advocate on getting enough protein.
Yeah, this is also a hot topic, protein and creatine. So I think probably for all women, it's important to get enough protein. And I think throughout all of our lifespan, we probably are not getting enough protein. But this is important for energy, especially in this community. We have a lot of patients who are super active, and getting enough protein is good for the body to have enough energy. Um, I think another important thing to remember would be like a whole foods, like leaning towards plant-based diet, where you're getting plenty of vegetables, plenty of whole grains. Really, a lot of the conversation and research in this area is around decreasing inflammation. So keeping healthy foods in our diet can help us decrease those inflammatory tendencies that can increase during this time. But yes, I agree. Protein is really important. I we prefer you to get it from your food than to be using protein powders. That's not means that you shouldn't use them or they're unsafe, but as much as you can, filling your diet with healthy whole foods.
Couple more questions. Um, do you ever recommend VIM in perimenopause for supposed estrogen dominance?
Um, I don't personally. So estrogen dominance is kind of a buzzword right now that you might hear a lot. Um, like we saw in those graphs, our hormones are going to go up. You're going to be estrogen dominant or have high estrogen sometimes and low estrogen other times. I don't think that supplement is dangerous by any means. And I think that if you try it and it works well for you, then why not? But I think we have to be careful when we use that term because there might be other things going on and it might be fluctuating a lot.
In postmenopause, is there an age or time to taper off HRT, or is it continued use acceptable?
Um, this is another kind of $1 million question right now. So in that critical timing hypothesis that we talked about, we generally say using hormones for the shortest amount of time is our preferred treatment approach. However, now that we are using hormones more consistently earlier on and maybe preventing some of these long-term cardiovascular disease, things like that, that we often see, we might start using them longer than we did in the past, but we just don't have the evidence or the studies yet to tell us exactly how long is safe. So this might be provider dependent. We do see that steep increase in risk around the age of 70. So a lot of times If it's been more than 10 years since you've gone through menopause, and you're getting into that age range, we will start to wean you off. The exception is vaginal estrogen, which everyone can have forever as far as most providers are concerned. But I anticipate this will continue to change as we have more and more research in HRT. And really, it's going to depend on your personal risk factors. So if you're someone that develops really high cholesterol, cardiovascular disease, you've had a heart attack, or a stroke, we're going to be a lot more hesitant to continue those hormones past that safer window.
Can you experience perimenopause without hot flashes?
Yeah, I think that even though it's the most widely recognized symptom, um, when I looked most recently, about 50 to 85% of women, that's a big range, but the upper limit was 85 of women experience hot flashes, meaning a certain percentage of women will not experience that, or they will be so subtle that they don't really recognize it. So you do not have to have hot flashes to get treatment for perimenopause.
Can you distinguish between adrenal insufficiency and perimenopause with lab tests?
So true adrenal insufficiency, we can establish with lab tests. That is going to present differently and sometimes more dramatically than perimenopause. But that is um, the disease forms of having low cortisol is something that we can diagnose with labs, and often providers can help decide if it's worth doing that lab testing because those symptoms are actually very specific, and they can get confused for perimenopause. There's also a lot of trends right now that we are very stressed, we're burnt out, we have adrenal insufficiency in general, but that's very different than true disease state forms of cortisol issues.
Can DHEA be taken vaginally for symptoms other than dryness, such as fatigue?
Um, so the vaginal DHEA is not going to be systemic. So it's going to be localized to the vagina. So I don't expect it to improve fatigue.
Are bioidentical hormones the same as HRT?
That's a good question. So HRT, or hormone replacement therapy. You'll also now see like MHT, menopausal hormone therapy. That is the umbrella term for hormone replacement. Bioidentical, if you remember from the beginning of the presentation, bioidentical hormone replacement therapy is when we use hormones that are identical to the hormones our body is producing. So these would be things like the estradiol patch or the micronized progesterone. So those are forms of HRT.
How can a Valley View patient participate in and direct individual treatments during perimenopause to manage their symptoms? I'm experiencing almost every symptom and feel I need a lot of hand holding, at least in the beginning, to help me manage.
That's where seeing a primary care provider can be really helpful. So many different providers prescribe HRT. So if you're a patient of our urology team, or our OB-GYN team, or any of our primary care clinics, but this is where primary care can be really helpful because we love handholding. That's part of our job, is to improve your health and your well-being. And so a lot of times when we are starting women on HRT, we like to see you frequently and check in and see how your symptoms are doing. So this is a perfect time to establish with a primary care provider, see your primary care provider if you already have one. And if they are not someone who is routinely prescribing HRT, have them refer you to one of the providers who are doing this, and we can go through it with you.
How does the body balance once you are not taking HRT? Will the symptoms come back?
Yeah. Sometimes it depends when we stop. We like to, if we're going to wean off, we like to do it slowly. And so we're not going to do abrupt withdrawal of the hormones. And so theoretically, that transition would be smoother. But there's also the concept of treating through the time period where those symptoms are really bad. And then on the other end, for postmenopausal, we stop them. You might experience some hot flashes, but usually the symptoms are not so drastic.
Two-part question. If you've been on birth control, like an IUD, for more than 10 years, how will you know if you're on perimenopause? And also, if you're in your late 40s and still on an IUD, how will you know when to go off it?
Um, Good question. So first part, so we aren't going to know. So if you have an IUD and you're wondering, am I perimenopausal? We aren't going to know based on bleeding changes, but you might still start to experience some of those other symptoms. So maybe hot flashes or maybe mood changes. This is one of those situations where sometimes we will check some hormone levels. We're not going to check your progesterone because we're giving you progesterone. But sometimes we'll check some of those other hormones to see where you are. Sometimes we'll just start you on some estrogen to pair with your progesterone to see if your symptoms get better. And if they do, there's our answer, and that's great. And then when to get rid of an IUD. So a lot of time, so average age of menopause is 51. So if you have an IUD, you're not getting periods, and you're around the age of 51, sometimes we will take your IUD out, see what happens. Sometimes we will leave it in until you're kind of past that time period in hopes that when we take it out, you don't get a period anymore. But really, when we're using the IUD, at that time, it's more for the period control. And if you start to have menopausal symptoms while you have, or perimenopausal symptoms while you have your IUD, we start treatment. Did that answer that question? Okay.
Is it true that you will begin perimenopause or menopause at the same time as your mom?
So there is some research to show that there are some genetic tendencies. So if you know what age your family member, so your mom or your aunt or your sister went through menopause and perimenopause, that might be an indicator for you as well. But everyone is different, and so it's not a guarantee, but it can be helpful to know when your mom went through these changes and what her experience was.
Can you delay perimenopause?
So perimenopause is part of the natural aging of our ovaries. So our ovaries age, we can't stop it, we can't prevent it. So we cannot delay it. Those eggs are going to be lost every month that we're cycling. And it's not just the egg you ovulate, it's also the whole crop of follicles that are growing. This is in hopes your body of making a baby. But all those follicles are growing, you're going to lose the main egg that you ovulated and the other ones that don't reach maturity. So we can't, right now, we can't stop that. The train is going.
And this will be our last question, Dr. Hoffman. Where do you see patients and are you accepting new patients?
Yes, I see patients at Roaring Fork Family Practice in the Willits location. I am here most days, and I am accepting new patients. All right, so we are going to, I'm going to go through some announcements. That's the end of our Q&A session. So our team would love to hear your feedback on the presentation today. If you have the time to fill out a quick survey, it's going to appear right after this webinar ends. You will receive an email with the recording of the webinar within the next 24 hours. The next two Valley View University presentations are on February 25th at 12 p.m. with physician assistant Sonia Fauché, and she will present on chest pain and heart failure in women. This will be the last of the women's series presentation. And then at 6 p.m., Valley Ortho provider Dr. Thomas Pevney and physical therapist Jessica McElroy, they're going to share tips and live demonstrations on how balance and stability support long-term knee health. Thank you all for joining and have a great afternoon.